I suppose I've always thought that no matter what the particular syndrome the young person is struggling with, they're most fundamentally, a young human being, and that's the basis we have. And in many ways, they're unique, but they do have some things in common with each other. And the old idea, which was based on, I think, stigma within the mental health field, regarded the psychotic patients as somehow, different or even alien in some ways, and the patients with more common mental disorders a different class. But there's so much comorbidity anyway, and these are really syndromal terms that we use. So it's not a very helpful way to think in such a rigid sort of way about what's wrong with them. The treatments actually, most of the treatments we offer are relatively non-specific, and they do cross diagnostic boundaries anyway, like psychological treatments and social treatments, and many of the medications we use across diagnostic boundaries too. So the value of rigidly putting people in boxes it really has to be justified, I think. Those young people who have what we call sub-threshold symptoms of various kinds, they might be low-grade psychosis, they might be mood and anxiety, very commonly they have all of those. Now, their functional impairment is very significant, even though they might not have met a diagnostic threshold. So the point is that the need for care of some sort precedes diagnostic clarity in terms of our traditional DSM or ICD systems. So they need some sort of help. There are large numbers of these young people, in the community, and they benefit from help. So how to provide that care is something that we've worked on, and we have to develop a strong primary care system that suits young people, which has been done in Australia with Headspace. It's been done in Ireland with Headstrong and Jigsaw. It's being done in Canada and Denmark and many other countries. So we're developing this entry point, which hopefully prevents you having to triage people, because everybody can come and at least get an initial assessment and support. Well, I think triage is a problem because if you think about its origins, it's from wartime, where you're trying to decide on who's worth saving and who isn't, in a battle situation. And that's not what you want to be doing in medicine and in healthcare. You want to be responding to people's genuine needs. And imagine if you decided you were going to apply triage to breast cancer, and you say, well, okay, I think your breast cancer is more worth saving than yours, and we're going to exclude you from treatment. That's what happens in mental health at the moment.